morning, everyone. This is Sharon Terry from Genetic Alliance, and welcome to our webinar series, Managing the Mass of Measures, Real People's Real Data Made Useful. We're delighted to have a webinar today on common data elements, which we'll talk to you about in just a moment. This webinar is part of a series that we're running the entire year because we discovered as we moved into data elements, standards, instruments, validation, etc., that there's a whole host of these, and there's lots to say about them. They become more and more important as we all move into translational and clinical science, and especially as we start to share data broadly. Lots of efforts that you're all aware of and more have begun to look at how do we do these in a networked way. So we're very happy to be able to present this series. A bit of housekeeping. This webinar is recorded. And so you will not only have access to the slides, but also to the complete audio transcript file. About a week or so after the webinar, you'll receive an email from us that will tell you how to access the webinar archives. They're pretty easy to find on our website anyway. And so if you've missed any of the webinars leading up to this one, not that these are dependent on one another, but certainly they are complementary to one another. You can go to our website and look at the webinars that have preceded this one. We're running these about once every 2 or 3 weeks, a little bit slower during the summer, but we're delighted today to have Jerry Sheehan from the National Library of Medicine talk to us about common data elements. Again, the webinar is recorded. You will have access to the slides and the audio recording. If you have any questions, we are not going to unmute the phones because we have more than 150 people registered for this webinar, and that would cause amazing chaos. We ask you to type your question at any time at all during the webinar in the questionnaire question portal, which is on the right-hand side of your screen in the dialog box that comes with GoToMeeting, GoToWebinar. You can just type your question there. I'll spend the webinar collating those questions so that I can ask them to Jerry in a somewhat reasonably orderly manner. That doesn't always happen terribly well because we're doing this on the fly. But again, we encourage your questions. We invite you to put them in the portal. And this, both the presentation as well as the question period, is recorded, and the slides are available on our website. So without further ado, Jerry, I'm turning it over to you.
Okay. Well, thank you, Sharon. I want to thank you and Genetic Alliance for inviting me to present in the in this webinar series. I think, as you noted, the topic is timely, and I think what I'll present today should be hopefully a good complement to what is being presented in some of the other webinars in this series. What I'm going to focus on today is really an overview of a set of activities that are taking place here at NIH. That are being organized through a working group, trans-NIH working group, that brings in representatives from, I'll say, most of the institutes and centers here at NIH. And so rather than focusing on a particular CDE or Common Data Element Initiative, I'm going to give you an overview of what we're trying to do to coordinate NIH efforts in this area better. And our timing is interesting in that I think we're at a point in our work here where we've been for about the last 2 years trying to coordinate efforts across NIH, a bit of herding cats and moving people in the same direction and building some common understanding of what we mean by common data elements and how they can be used. And we're probably now at a point, kind of an inflection point, where we can think about developing more of a strategy for how to move forward in a more integrated fashion in this area of common data elements. And so I won't be able to say as much today about what that strategy will be, but actually I'm hoping through the discussion that we'll have an opportunity to perhaps solicit some ideas from the other participants about how we can best do that and what we need to be aware of in the greater environment. Okay, just one note. I think originally when we'd scheduled this webinar, I was going to be accompanied by a colleague from NIH, Joanne Odenkirchen from the Institute for Neurological Disease and Stroke, to talk about the NINDS CDEs. She is unavailable to do that today. I'm hoping we can maybe reschedule her for the future date. So what I'll be doing is really giving an overview of this Common Data Elements Initiative across NIH, and will not be focusing specifically on the NINDS CDEs, but I'm going to mention them as we go ahead. So oops, let me move to the next slide if I can. All right, so in terms of setting the stage, and this may be more background for this group in terms of why NIH is interested in common data elements, we have recognized, as I think the biomedical research community may have recognized as well, that our research is increasingly data intensive and data driven. So you've probably heard of the Big Data to Knowledge initiative across NIH, which is a reflection of this growing awareness and an effort to greater coordinate NIH efforts around data in the biomedical research enterprise. And a colleague and I, about a year ago, tried to look at an estimate of how much data is, I'll say, NIH or NIH-funded research generating. As you can see on the slide, we estimated using our PubMed Central resources that NIH funded research is producing about 115,000 research papers per year. Most of these, in fact almost all of these, should be available to you through PubMed Central as a result of the NIH public access policy. We took a sample of these papers and tried to understand not the quantity of data that they generate in terms of terabytes or the number of variables, but how many data sets, if you can define what a data set is, are typically collected and analyzed in these studies. And when we looked across a broad number of studies in a range of different fields, we found that there are on average about 3 data sets per paper. The range, as you can see, went up to about 120 data sets by some count. And if you think through that, that gives you on the order of 450,000 new data sets that are being generated per year, of which human subjects research seem to account for about 25%, or a little over 100,000 data sets. That's quite a bit of data being generated every year. And of course, there are multiple variables contained in each of those data sets. Just turning to a couple of the maybe more well-known databases that contain some of this study data, in dbGaP, which is the NIH or the NLM database of genotypes and phenotypes, we now have 488 studies. These are genome-wide association studies that have collected more than 3,000 data sets, in total about more than 145,000 different variables collected in them. In clinicaltrials.gov, which is our registry and results database of clinical studies, we get about 19,000 new studies registered each year. So that the total volume or total number of studies that are now described in clinicaltrials.gov is more than 170,000. These are virtually all diseases and conditions around the world. We now accept summary results information of those trials and have now more than 13,000 results records that describe the demographics of the patient population, baseline condition, outcome measures, and adverse events overall and by the arm of the trial. In any of these records, we have typically a primary outcome measure and multiple secondary outcome measures. You can see the median numbers there, about 4 different secondary outcome measures per study. In some cases, or in one case anyway, up to 172 different secondary outcome measures. So there's quite a bit of data and quite a number of different variables that are collected. In that set of 13,000 results, there are about 4,500 studies that use depression or some measure of depression as a primary or secondary outcome. And you can see that there are a number of particular rating scales or inventories that are used to collect that information: the Hamilton Depression Rating Scale, the Beck Depression, the Montgomery-Åsberg Depression Rating Scale, the PHQ-9. There are many, many others as well. Right, so this information about depression is being collected in many ways across these kinds of studies. When we looked in CADSR, which I'll say more about later, which is a repository of data elements that have been used in cancer-related research and other fields, there are more than 100 different data elements, ways that people have collected information about depression. Some of these are components. There are individual questions in the rating scales. For the Beck and the Hamilton inventories, for example. When we look at things like smoking and smoking status, have you ever smoked? How many packs a day? There are about 192 different data elements that have been used to collect that kind of data. So the challenge, of course, is how do we make sense of this variety of data that's being collected in many studies so that we can make better use of the knowledge that's been developed. There are many approaches you can take, and one of them that a number of institutes here and groups of institutes here have been taking is through the development of common data elements. I don't want to offer a very formal definition of common data elements, a bit because we're working with various approaches that have been developed in different initiatives, but just to give us a kind of a common framework for thinking about common data elements, just a couple of ideas. When I talk about common data elements, we're talking about is a kind of a fixed representation of some piece of data or variable that would be collected in a study, typically within a particular analytical or clinical domain. Although some of these may cross multiple domains if we're talking about things like medication history, even basic patient demographic information that may span multiple clinical domains and disease areas. We think of a common data element as consisting of both a question and an answer. So this may be the question, have you ever smoked? And the set of answers being either a permissible set of values, yes, no, or it might be a format, a number between 1 and 1,000 for another type of value. And it's the combination of the question and the answer that comprise the common data element. We'd like to think that common data elements could be defined unambiguously using different terminology, different structure, in ways that are understandable to both humans and increasingly in machine computable terms, so we can combine data in more automated ways. And if we think about CDEs as being this kind of question and answer package, we recognize that they're combined in many ways into more complex survey instruments, case report forms. And sometimes it's those case report forms as a unit that have been, say, validated for particular use, maybe more so than the individual data elements that are combined into them. So we need to keep that in mind too as we think about these common data elements. Within and across NIH, there are a variety of different motivations for common data elements. As I mentioned, one of the strong motivators for doing so is this notion of being able to compare results across multiple studies of a particular disease in a particular intervention area. In some cases, use of common data elements might also enable us to aggregate data from multiple studies, especially as we're moving into an environment in which data is increasingly accessible in publicly available or perhaps controlled access repositories. And by aggregating the data from multiple studies, we may get greater statistical power and reliability in our results and begin to detect kind of weaker signals that you can only see when you've collected data from a much larger number of participants. The other advantages or of benefits of common data elements are really in trying to speed the study startup. In particular, in clinical research, we know study startup can be slow. If we can help people by giving them a menu or a set of data elements to select from and incorporate into their study rather than developing them from scratch, might speed that process up. We may also be able to improve the quality of the data that are collected by encouraging the use of measures and case report forms and so forth that have been validated for particular uses. And of course, in an environment where there's increasing attention to problems of reproducibility and replicability and replication of studies, having greater, more widespread use of validated instruments may be a way of enhancing reproducibility. Also, knowing the particular way in which data were collected may also contribute to increased reproducibility. So as I said, a number of institutes and centers at NIH have been actively involved in different types of common data element efforts. And for several years, they had been working in groups and individually in the development of different types of initiatives and tools and resources related to common data elements. About 2 years ago, after a group called the trans-NIH Biomedical Informatics Coordinating Committee, or the BMIC committee, which you'll see on the top of my slides, had heard presentations from a number of these initiatives. One of the questions, of course, was whether or not these initiatives were talking to each other, since a number of them were investigating diseases or very similar diseases or the same diseases. And that committee established a working group on common data elements that the charge is listed on the slide here, which is essentially to improve the coordination and communication of common data element initiatives and promote the use of common data elements across NIH. The specific items that the working group has been pursuing over the last 2 years or so are listed here and center around, one was the creation of a web portal that I'll show you some screenshots from in a moment, encouraging the use of CDEs by NIH-funded investigators, trying to better coordinate CDE development efforts here at NIH and in related communities to address these concerns about overlap or possible redundancy, or what we call near misses, where two initiatives had come up with different ways of collecting what seems to be very similar information and where there may be opportunities for greater harmonization. We were also aware that there was other work going on outside of NIH to develop common data elements and related data standards. We wanted to make sure we were integrated with those efforts. And we want to make sure the NIH staff here internally, as well as the extramural investigators, can identify and use relevant CDEs in their work. And I think the interesting thing is we now have representation from about 22 different institutes and centers on this working group, not all of which have been involved in developing common data elements themselves. Many of them are there to listen and learn and think about how they can plan and incorporate kind of this concept into their future work activities. When our group got together and started inventorying the activities that were taking place across NIH, we ended up clustering them into two bins or two categories. The first were what we think of as CDE initiatives, and these were really attempts to identify standard data elements or sometimes data collection instruments for use, many in clinical research, some are for use in patient registries or in surveillance activities, and all entailed some type of a vetting process to select CDEs. So there's an element of selection here. We're looking at a variety of ways in which particular types of data could be collected, and we're giving preference or priority to those. That vetting may have been through a fairly elaborate experimental validation of questions and questionnaires and case report forms. It may have been in cases where that type of validation wasn't possible or didn't exist yet, based on expert opinion. What are the most valuable data elements to collect in a particular area? And so these initiatives, in essence, give you some sense as to what kind of information you should be collecting in a study, and more specificity about how to collect it. We contrasted that with what we were calling tools and resources, which consist of different types of databases and repositories that contain data elements and case report forms, but have much less vetting of the content. They may have certain selection criteria for a particular field or a particular domain. They may even have some uniform standards for metadata to describe the data elements or the forms that are contained in them. But what they tend to do is provide more of a broad set of examples for how data are collected in different fields, less selection and prioritization of which are recommended. But many include different tools to allow people to see how often is a particular data element used, what kinds of investigators use it, are there opportunities for kind of comment and feedback from them individually to understand which I might use in my study. To give you a sense of what we put in these two buckets, so the NIH CDE initiatives are kind of represented on this slide, and I think in this webinar series you've heard about a few of these already. The Phoenix initiative, which is really linked to genome-wide association studies and is developing or identifying 15 or so recommended data elements or concepts to be collected across different disease areas, and these run the gamut from things like cancer to cardiovascular disease and diabetes to neurology and psychiatric diseases as well, now moving into areas such as obesity and smoking, tobacco use. The NINDS common data elements are developed for use in NINDS funded studies. They have identified a core set of data elements they want collected in all NINDS-funded research, and then disease-specific data elements that have been identified in about 14 different disease areas: Parkinson's, stroke, TBI, different neuromuscular diseases, and with more to come. And then they have a number of kind of supplemental or recommended extensions of those data elements. Promise, which I think has also either been presented or will be presented within this webinar series, is a set of patient-reported outcomes for physical, mental, and social health, validated instruments for that. And I'll just point out at the bottom the Global Rare Disease Patient Registry and Data Repository, which is has identified a number of common data elements for use in things such as basic demographics, diagnosis information, medical history, to apply across what would be a set of disease-specific rare disease registries. So this is more of a registry approach than a research approach, but of course there's a link between the two of those. The types of things we put in the bucket of CDE tools and resources are repositories such as the CADSR from the National Cancer Institute, which, as I mentioned, houses on the order of about 46,000 different data elements that have been used in cancer research and related studies, some of which have been vetted and identified as standards to be used in cancer-related research. NCI has also produced something called GEM, the Grid-Enabled Measures Database, which is a database of behavioral and social science measures, and combines those measures with different types of Web 2.0 tools for commentary, rankings, and other sorts of ways of getting feedback on the measures to help others identify which are most relevant to their studies. What's on the right-hand side of this, this slide are essentially large NIH-supported databases of different types of data, TBI data in the first case, autism research, Parkinson's disease research, and then GWAS studies, where there are data dictionaries available. They're often, in the case of dbGaP, access to the underlying protocol so people can see how data was collected in different studies and can use that then to inform their own selection of data elements. One of the next things the working group did was to develop and launch a web portal, and this was launched in January of 2013. You can see the URL on the screen here, which was essentially an attempt to provide a one-stop shop for information about NIH CDEs. And you'll see, again, we've kind of followed this distinction between initiatives and tools and resources to give people a better sense as to what they might find as they move through the portal. The portal is just that. It is a portal. It's a window to provide you with access to additional information about these initiatives. It doesn't provide you direct access to it to the data elements. It is not a repository of the data elements yet, although there's some thinking going on and some work to move toward a repository, and I'll say that words about that at the end of my remarks here. I think if you Google NIH CDE, this will be the first thing that would come up on your screen. And just to give you an idea of what you would see, sorry, if you clicked on the summary table for CDE initiatives, you would get something like this. Actually, you would get this, which gives you a list of the 9 initiatives that we've identified, provides you access to the home page, to their catalog of CDEs, provides summary information and an indication of the subject areas that they cover. If you were to click on, for example, the NINDS Common Data Elements, what we would do is take you out to the NINDS Common Data Elements page, from which you could, if you clicked on the Tools bar and then looked through their catalog of data elements, bring you access to, for example, under the traumatic brain injury, if you looked for assessments and examinations, here's a list of the data elements that you would find. If you were to click on the first one of those, which is electronystomography results, you would get access to a description of the common data element. In fact, this description runs off the screen, runs off the page, but gives you information about the name of the CDE. You'll see information in the middle about the permissible values for that CDE and the data type, etc. So this is the type of information you can get to from the portal itself. If you were looking for more information about the initiative, you could go back to the brief summary. If you click on the more, you would get a brief summary here of the initiative. I think I would point out on this information about the a reference to provide a publication with more information about the initiative, some information about the provenance of the data elements that are there. Are they drawn from other collections? Are they developed by the expert groups that were assembled for this project? How are they available? Are they available for free? Is there registration required? And under the last element, information about whether there are certain core CDEs that are in mandated use, or are these expected to be used in particular types of studies. We also give you a sense, kind of on a single screen, of what subject areas are covered by these CDE initiatives. So the list of subject areas in the left-hand column comes from the Phoenix initiative and has been expanded somewhat to accommodate some of the other CDE initiatives. But again, just to give you, since we did not have a search function to pull out relevant CDEs, just a way to give you a single screen with information on what topics are covered by these initiatives. So the portal itself gets several hundred users per month, most of whom are directed by one or other NIH websites or come directly. I think we have some traffic, about 30% now coming from Google. And we're continuing to enhance and expand it. We've already identified some additional initiatives that need to be added to that resource. You can see a list of some of the challenges that we face. What I think I'll do is give just a quick summary of some other things that the group is now working on to give you a sense of our future work plans. First is trying to promote greater awareness of these CDEs and their use among various stakeholders. We're also now trying to use the working group to coordinate among the CDE initiatives to help reduce some of these overlaps and near misses. And we've started collaborations with a number of different external and HHS groups. I'll say a bit more about that. And we're continuing to look for more convenient ways to provide access to these common data elements. Outreach has been through a variety of different channels: internal publications, external publications, presentations such as this one to make people aware of the common data elements that are being developed. And we welcome suggestions for other groups that we should be meeting with and communicating with who may be interested in a variety of different communities, those who are more in the informatics side of the world, those who are involved more in the clinical research or the patient registry side, advocacy groups, and others. You will, well, the research community will see that NIH has been taking steps to encourage the use of these common data elements. So in different funding announcements and conditions in terms of awards, there's various types of language that is being used to either encourage the use of these common data elements, or as you'll see in some of these examples here, more directive language. So the Parkinson's Udall centers, they must utilize the NINDS common data element resources. NIDA is strongly encouraging investigators, in some cases, to use their substance use and addiction collection. So this kind of language ranges from being inspirational and encouragements to much more directive requirements and expectations that common data elements will be used in particular research. We've been looking for ways and discussing ways of kind of extending and broadening the reach of the encouragement to use common data elements. And we've developed some language that is appearing in a number of additional funding opportunity announcements, which essentially says if you're collecting data in your studies, and in particular would be submitting a data sharing plan to NIH, that we encourage you to use common data elements where they are applicable to your work. And what we've done is provided some direction to what we mean by a common data element is one of the resources that's listed on our portal. And we encourage you to consult the portal and describe in your plan how you would make use of NIH-supported CDEs. So this has now appeared in a few funding announcements from different institutes, and we expect it will be increasingly used as to provide encouragement. We've also been working both internally and externally to kind of share some lessons learned from the NIH efforts so far. These kind of well, they're summarized here. Everything from starting with don't reinvent the wheel. One of the things the working group was established to do was coordinate activities and sort of preclude new initiatives that were operating without taking advantage of existing capabilities and existing data elements. We're encouraging cooperation and coordination with others, promoting the use of validated data elements and instruments when possible, noting that not all the instruments have gone through a kind of a robust validation for all the populations for which they might be used. Encouraging range of expertise, domain experts, clinical experts, informatics experts, and patients as well in developing new common data element initiatives. And developing, for example, communication strategies and policies to promote the use of CDEs. We came across a few sets of CDEs that had been developed, but there was not much of an active program or plan to promote their use. And so we think that needs to be part of any kind of activity around common data elements. We've been thinking about common data elements in the context of the Big Data to Knowledge initiative. There was a workshop on research use of clinical data last fall that came out with one of the findings being that there were opportunities for us to support and coordinate our work on common data elements and give it greater visibility. There's related work on community-based standards that might provide a platform for developing more of a strategy for moving ahead with common data elements across NIH. I mentioned interagency collaboration. I'll say just a word about two collaborations. One is with the FDA, which those here may be aware of, work to identify or develop data standards for in the order of 60-plus priority therapeutic areas. And these are areas in which FDA expects to receive applications, marketing applications, in coming years. I won't expect you to see this study this slide too closely, but work has begun and has progressed quite far in identifying and identifying key data elements and then developing them into CDISC type standards for submission of data to the FDA. NIH has been engaged in this activity in areas in which we have developed CDEs, helping provide some of the clinical expertise and trying to ensure that the data elements that are brought into this process are as closely aligned with those that have been developed at NIH as is possible. We've also been working with the Office of the National Coordinator on the Structured Data Capture Initiative, which I will summarize in a couple of words to say is looking at identifying standards so that an EHR could pull in data elements in a specific format that are identified for use in a research study, populate information into those forms using data extracted from the EHR where possible, prompting a clinician to collect the additional information that's required for the study, and then sending it off into an external data repository. What this is done is identified and recommended standards for both representing common data elements or data elements and for generating forms from them. We are working with them to ensure that our work is aligned with those standards and to understand the types of resources that would be necessary to have NIH common data elements kind of put in the context of the SDC initiative. There are many, many opportunities for collaboration. I list just a few of them here to give you a sense of the other types and groups of people we are talking to. It's a complicated process because I think as you're seeing through this webinar series, many people are interested in common data elements now. Where we at NLM have been trying to bring in some additional expertise is on the back end, if you will, trying to help match common data elements and the terminology that is used in common data elements to the kinds of data standards that have been developed for electronic health records, and through the Value Set Authority Center, or the VSAC at NIH, to link them to value sets that have been identified for quality measures under the Meaningful Use program within the Office of the National Coordinator. We're looking for ways to reduce overlap across the NIH CDE initiatives And one of the efforts that we've been undertaking, this is with support from ASFI and others across the department, has been to develop a prototype data element repository that could become a platform for not only providing access to common data elements, which could include the NIH common data elements and those from other, say, HHS agencies, but also a platform for helping us identify and reduce redundancy across the data elements that have been developed. So this has not yet been launched, it's still in an internal development phase, but gives you an opportunity to search for and identify existing common data elements. And using some functions that we're testing now, the more like this function, can we find data elements that look very similar so that we can then bring them to the attention of these various groups and work on merging them and reducing the diversity of ways in which similar data is collected. So to kind of bring this to a close, we're continuing to identify other relevant efforts, trying to also understand where there are gaps in the common data elements that have been identified, where there are other diseases and conditions that should rise in priority. We're continuing our outreach to internally here at NIH and to external groups. And we're also trying to understand the use and impact of CDEs. How have they accelerated research? How often are they being used in studies? That's still kind of in its early stages of development. As I mentioned, we'll continue work on the prototype repository and on developing processes for harmonization and integration, which is more challenging than it might appear on the outside. So I'll finish just by pointing you to some additional resources, the NIH web portal, the associated BMIC website, the information about the BD2K program, and of course there's other information on the NLM website. So I think that finishes my prepared remarks, and I kind of look forward to the discussion as an opportunity to hear from the participants about some of their questions, concerns, and other things that we should be considering here at NIH. So thank you very much.
Thank you, Jerry. That was really terrific. As you know, we often have more than one presenter for these because it can be hard, both on the presenter who's speaking to about 100 people at this point but can't see them, as well as on the audience because of having one. And as you said in the beginning, your co-presenter was unable due to an emergency to present, but you did a fabulous job. That really was terrific. There are those who say that common data elements aren't that all that exciting, but you have retained the audience's interest and have done a great job. Also fascinating to me, having led probably 100 webinars over my years at Genetic Alliance, you pretty much answered everyone's question about a minute after they posted it, which was quite amazing. You are a man who knows your audience. But I am going to ask for a couple clarifications on things that you did touch on because they're complicated concepts. So if it's okay with you, some of this will be a little redundant from what you said, but I think is important to just make sure we have clarity.
Yep, happy to do so.
Great. So a question about the integration between NIH efforts and CDISC. And we haven't yet had our CDISC webinar, so you should feel free to say a word about what that is. And the specific question is, does NIH automatically defer to any existing CDISC data standards for new clinical studies?
Okay, so the short answer to that is no, we don't automatically defer to those, although I think through our collaboration with them, you know, we're I'll say paying closer attention to CDISC standards and trying to understand better how they could be used within kind of an NIH environment. Our collaboration with them, and this is part of something called the CFAST initiative, which is developing and identifying the data standards for these 60+ therapeutic areas. And our main interest in doing that, well, is maybe twofold. I mean, one is ensuring that where the disease areas that they are looking at overlap with our common data, existing common data elements, can we bring in our common data elements into the effort, which then kind of maps them into this, the CDISC standard, which is used primarily by industry when submitting data to FDA and other regulatory authorities. And so part of that, trying to guard against different sets of standards and different data elements being identified in those initiatives that would diverge from those that are being used in the NIH-funded community. And I think this speaks to the issue of translational research, where we would, as much as possible, like to get the clinical research community, aka the NIH-funded community, in line with what's happening in industry. And I don't think that means either side necessarily adopting wholesale what the other is using, but often trying to move together to identify areas of common interest. So we are contributing both where we have existing common data elements that we'd like to see kind of mapped into some of the CDEs standards, and in areas where we don't yet have common data elements, we're trying to bring in relevant clinical expertise to help this process identify what are the key measures that are collected or should be collected in studies in particular disease areas that can then be kind of put through the CDEs process. And there are others involved. The CPATH is involved in that. Transcelerate, which is a group of biopharma companies, and I know I'm forgetting one other key participant in the FDA, of course, and others as well.
Great, thanks very much. So there were a couple questions about the kind of proliferation of CDEs, and to the newly initiated, this is certainly somewhat overwhelming. And the questions really looked at, are there ways that you see that are productive for coordinating? And I know you did mention quite a number of efforts that NIH is undertaking, which is fabulous, because I think 10 years ago we would have been looking at not much coordination. But the basic question is, can these competing CDEs, so to speak, be harmonized given the work that you're doing, or do you think that's hopeless, essentially?
Well, I would say this. I think it's a heavy lift to do, but it's one that we are trying to make progress on. And where we are, what we've been trying to do is kind of twofold. And one I'll say is starting close to home, which is trying to bring some greater harmonization to those things that NIH has identified or blessed and vetted and is encouraging people to use. And then through the collaborations that we've established with, for example, the CFAST initiative, through our communication and activities related to the structured data capture initiative, which really pulls in a number of other HHS agencies. And I think and I should mention as well, I think I went over that slide quickly. I mean, within the CoreNet infrastructure, within the healthcare systems collaboratory, we're at the point where we've mapped out who a number of the key players are, but of course I don't think we've identified them all. And we're working now to figure out what the right strategy is to move forward, because as I'm sure you and many others on the call would recognize, that trying to get consensus or agreement even on a single particular data element, I mean a demographic data element about race, ethnicity, gender, smoking status, and others, it can be quite complex because there are often legacy systems to take into account. There are groups that have designated these as the preferred common data element that either may need to be reconvened, might need to come in and agree to a change in what they had previously put forward. So it's this kind of governance process around that is quite complicated. What we hope to do within our group is pick off a couple of data elements or concepts to try to bring closer to harmonization, so that we can use those as test cases to understand, what's involved in the process, what kinds of decisions and trade-offs need to be made in kind of reconciling different views of things, and realizing where there are some fundamental differences that need to be maintained. And I think, for example, we had some discussions about sex and gender data elements where there are differences between phenotypic and genotypic sex or gender, and maybe an administrative sex or gender to be put on a form. And you might need to respect those differences in the end. But maybe in each of those areas we could come up with the preferred way of collecting the information and the preferred kind of set of possible answers or values. So I think it's hard, and I would welcome and appreciate others' suggestions and advice for how to best proceed, because it is complex, and there are a growing number of groups that are trying to that are operating in this area now.
Super, thank you. Now I'm going to put about 3 questions together in one question, and that is, so if somebody would like to start using CDEs in a certain indication, is there an index across all CDEs so they're easily discoverable? You did show the website where they're aggregated, but is there an index so that you can just look for an indication? I'll stop there actually and have you answer that first.
Okay, so yeah, as you saw in the portal that I showed, there's not a, what we've tried to do there is aggregate things so you could see in your particular domain what might be the 2, 3, or 4 different NIH CDE initiatives that have data elements in that area. And someone would then have to go and kind of pull those together from those various sites to see which might be the most appropriate. That's part of the challenge we're trying to address with this concept of a prototype data repository, that if you could put some set of the data elements in one repository and create a search capability across them, you would be able to pull them up and retrieve them and compare them much more easily. There are some existing repositories. I mean, CADSR is one now that has quite a large number of data elements in it, has search capabilities and some comparison functions as well that could serve as a platform for doing that. And those are probably the current approaches that could be used, at least for the NIH sets of CDEs.
Great, thanks. Then 2 questions together. So if a research group or an informatics group from a major medical center, university, CTSA, advocacy organization wanted to participate with you all at NIH in this work, we saw that this is a working group across the ICs. Is there a way to do that? And second part of that, are there other venues for individuals who are interested in CDEs to get together in conferences? Are there publications that would be useful to individuals or organizations or research groups that wanted to use CDEs?
On the first part of that, which is sort of getting engaged with our work here at NIH, so there are probably 2 routes, and I think both of them should be pursued simultaneously. One can be to contact me. Actually, I see you've got my contact information up on a slide there. The other is in particular for those groups that have some affiliation with NIH, the CTSAs and others, also contacting their kind of parent IC, because as I mentioned, most of the ICs are represented on the group already, and that can be another good channel for engaging in the work. Other venues is a difficult one. I mean, we've been finding various venues in which people have been discussing common data elements. One example is an initiative that actually comes out of the European Union, which is a COMET initiative, Core Outcome Measures for Effectiveness Trials, which is trying to do something very similar in terms of identifying initiatives that are trying to narrow down the sets of or identify a set of recommended outcomes to be measured in particular types of studies, whether it's of a particular class of drugs or around a particular disease. There are, I'm sure, within groups like within the American Medical Informatics Association and others, there are groups that look at data standards of various kinds, and there's been some interest in common data elements within those groups. But I think much of it is still, I'll say, somewhat scattered and overlapping with interest in health information standards overall, and probably not a single forum in which these discussions can take place. I guess maybe the other I'd mention, I mean, within the Office of the National Coordinator, there is the S&I framework, under which this structured data capture initiative has been taking place, and I think that's also an open forum for people who are interested more in the general discussion of common data elements, that I say more in general than in, say, a particular disease area, can participate in that activity and provide contributions into the work of that initiative.
Right, great. And I can vouch for them being very open. Genetic Alliance has begun to work with them after a presentation they gave at the Standards Committee meeting. Okay, a little theme here. So if anyone looking at any sort of, is anyone looking at any sort of CDE that addresses consent, privacy, and the future use of collected data? And together with that question, I'm also going to ask, are there any CDEs that address patient identity using an anonymous private key as data comes from multiple sources, so that the data can be combined across patients?
So sorry, I think I missed part of the last. I mean, a CDE for patient ID that would allow.
So a CDE that would address consent, privacy, and future use. So in other words, one could imagine that we would somehow come together in some kind of common data elements around those things, and then that there might also be an anonymous private key that could be attached to one of these, perhaps as part of the code, that would let data that comes from multiple sources be combined so that you knew you were looking at the same person.
Okay. So I'm not aware of a CDE in terms of specifying consent and future use, but of course, as NIH and other groups have been working on various policies to promote the reuse of data, and I think one of the priorities within that has been to ensure that data are collected and used in ways that are consistent with the informed consent. There's probably an opportunity to think about how that could be done in a more, I'll say, standardized way or structured way, consistent across various types of studies. So I think that's a very good suggestion. With the, in terms of the patient ID, there has been work at NIH, and probably in collaboration with others as well, to develop something called the GUID, which is the Global Unique Identifier, which is essentially an encrypted or an identifier based on an encryption algorithm that is based on some patient demographic information, which does allow, say, various multiple records from the same participant to be combined and aggregated in a way that protects their identity and their privacy. And I believe, for example, that's being used in it's called FITBR, which is the Federal Interagency Traumatic Brain Injury database, as well as in the National Database for Autism Research. But I think that same basic functionality could be used more broadly across different databases.
Great, super. Okay, so NCI has many CDE initiatives, but you seem only to be looking at the NCI CADSR as a set of tools. What about the hundreds of standard CDEs and forms? Are they also being considered?
Short answer is yes. I mean, we are considering those, and we have been. So NCI is part of our working group. We at NLM have also been working very closely with NCI in recent months to kind of understand what each of us kind of brings to the table in terms of existing capabilities, data repositories, CDEs, and so forth, and how we can best kind of leverage those as we move forward in this area.
Great. How will data be filtered and integrated into the EMR, which will facilitate shared decision-making in the clinical setting?
Yeah, that's a great question, isn't it?
Jerry, just solve that one.
Well, I mean, I think I would, in that, point to what we are trying to do with common data elements here, and has probably not been the practice so much to date. Is looking at CDEs and trying to where we can kind of map them back to some of the standards and the terminologies that have been identified for use in EHRs, kind of in the meaningful use context. So things like RX norm for drug names, LOINC as an identifier for observations and lab tests and such, SNOMED terminologies, so that both questions and in particular kind of the answer sets or the value sets use EHR terminology, and I think our hope with that, our expectation with that, is that that will improve the interoperability between EHR systems and clinical research systems. And which way the information flows, I'd have to say we've been thinking about it more from extracting from EHRs than input into EHRs, and that has to do with kind of questions of ownership of the data and so forth and what the EHR reflects. But I think that the consistency between them can improve that kind of interoperability in both directions. But it's also something that's I want to say not simple to do, and is kind of part of an enhanced curation of these common data elements that is kind of yet to be applied. The NLM experience with that has been in taking some of the quality measures that were identified in meaningful use and mapping them back to the so-called value sets that are expressed in SNOMED and LOINC codes and terminologies, so that we've got a kind of more set understanding of what in these quality measures, essentially, how do you measure the numerators and denominators.
Super. So I'm actually going to take you off the hook, Jerry, for just a minute. I'm going to answer a couple of questions that we could easily answer. They're more logistical, and then I will thank you because we're almost at the end of our time. So a couple questions that are just quick to answer. CDISC is proprietary. Isn't that an issue? We will be having a CDISC webinar coming up soon. That's a great question to ask them. And my understanding is that for nonprofits and for some of the research institutions, there are some ways that that is less an issue, although anything proprietary, of course, has some encumbrance. I don't know if you want to add anything to that, Jerry?
Well, no, I think that would be a good question to bring up during that discussion. I think there's greater openness about use of the standards now, to my understanding, and I think a number of the standards documents are available now with a much more easy download from their website.
Right. And I think it's a great question because it goes to business model as we all try to coalesce around some shared and open both standards and ways of doing things, because of course, as Jerry's mentioned, this is taking an enormous amount of work. There are groups that have disbanded since they created standards. Standards should not be abandoned or orphaned and need to be continually interacting with the rest of the world as it progresses into, for example, self-reporting devices and other kinds of ways of collecting data. So that takes resources, and sometimes it is the federal government or other publicly funding agencies, but sometimes it happens to be private collaboratives or nonprofits. Couple other things that I can just mention. There's a desire to get to know who else is on this webinar and who else is working on standards, which is a great question. What we will do is we will send a little survey to the 100 people or so who are on this webinar to see who would like to work together on standards and get things together, and then we'll be able to share that with all of you. There's a question about where to find the CDEs on the NIH website, and you can Google NIH Common Data Element and you will find them, or in our reply email when we announce the webinar's archive, we will send the URL out to all of you. So I really want to thank you, Jerry. We're at the 1 o'clock hour here. You have done a fabulous job. We really appreciate it, and we look forward to continued interaction over common data elements.
Likewise, appreciate the opportunity. Thank you.
Thank you. Bye-bye.
Goodbye now.